Welcome to SIIMcast, a podcast brought to you by the Society for Imaging Informatics in Medicine.
Greetings, everyone, and welcome to a special episode of SIIMcast. This is Jason, and in this episode, Prasanth and we recorded this at SIIM24, and we were in person with two esteemed members of the SIIM College of Fellows, Dr. Chris Roth and Dr. Alex Towbin. And our conversation focused on the 10-year anniversary of Enterprise Imaging. And in this conversation, we also play two voice notes from community members that share their reflections on a decade of Enterprise Imaging. Without further ado, let's jump into this episode. I hope you enjoy it. Thank you very much. Today is the opening day of SIIM24, and we're with two fellows today. Prasanth and I are here with Dr. Alex Towbin and Dr. Chris Roth, and we're here to have a little chat. It's going to be an open conversation, but we're going to do something a little different today. And we're going to kick things off by playing a few clips from the community related to their reflection on Enterprise Imaging turning 10. So I was going to say, what do the Beatles, Naps, Netscape, and Disco all have in common? They didn't last as long as Enterprise Imaging. So they...
Wow. So I guess the disco ball we were planning for the meetup tomorrow is not going to happen.
But this is Dan Sperring from the United Kingdom International.
Hi, my name's Dan Sperring. I'm a sales engineer with Highland Healthcare with a primary focus on enterprise imaging. First of all, thanks for the invite to contribute to this special episode of SIIMcast. It's a great honour. So yeah, in a nutshell, I've spent my entire career in medical imaging, always from the engineering side. I've worked in field service, global service management, and sales engineering across general radiography, mammo, and something a bit niche, which was time-lapse imaging of embryo development in the fertility specialism, which was extremely interesting. And now over the last 5 years at Highland Healthcare, I've really been working on this idea of bringing all this experience together through enterprise imaging. And I think it's been an interesting ride over the last 15 years. And if you look at the evolution of this concept of enterprise imaging, it's really accelerated over that time and continues to do so at quite some pace today. Going back to the 80s and 90s, of course, it all started with PACS and the emergence of standards in our field, particularly DICOM, which was all driven by this need to make sure that these new cool digital imaging systems, whether they were CTs, MRs, whatever, were able to present their images in a vendor neutral way. And I think really it kind of started out as a bit of a wild west of proprietary systems, mostly because digital imaging is complicated and hard. And each vendor therefore had their own way of decoding and displaying images from their own modalities, which obviously caused a new paradigm. If you think about previously when everything was film, you could easily share, albeit slowly, because film is just a physical thing you can mail or hand to somebody else. But now you have these digital images, good quality digital images, but they're super isolated. So DICOM and PACS then came along together hand in hand to tackle this interoperability issue. And, as we've moved forward and technology as a whole has improved, we've seen this shift where healthcare systems have seen the need as part of that diagnostic process, ranging from, your classic radiology, cardiology use cases through to dentistry, ophthalmology, pathology, obstetrics and gynecology, and so on and so forth. And we're seeing this concept develop, over the last 10 years of enterprise imaging, of this holistic patient imaging timeline, which is really supporting the patient's lifetime medical history and other structured systems like the EMR. And with the massive advancements that we've seen in imaging technologies supporting all of these different service lines, that timeline really now can stretch from almost like pre-cradle to post-grave, images of you as an embryo from the day of insemination and all the way through your life to the imaging used to support post-mortem autopsies. You really have that entire lifetime of imaging. And really, I think a lot of the advancements in EI are down to this drive towards digitization and advancements in the push of the EHR and the need to integrate this imaging content to that wider patient record is obviously pretty significant for health systems. And I think in a more recent history, the last sort of 5-10 years or so, the advancements in general computing technology really have provided the opportunity for imaging to become far more accessible to a much wider array of clinical users. If you think about the advancement in viewer technology, for example, most enterprise viewers now are thin or, preferably zero footprint applications, meaning that they can run on pretty lightweight hardware for the end user, like a bog standard laptop, PC or tablet in some cases. So without having to go and find a heavy duty, big old powerhouse workstation to view these clinical images, imaging is available outside the boundaries of the hospital, so stretching out into remote clinics and diagnostic imaging centres. And even where you start to see the integration of these viewers into the patient portal, you can then start reaching out into the patient's own home. And I think most importantly, it means that these viewers are far more easily integrated into the EHR, almost becoming a seamless part of that experience, a single click images. And when you make something easy and intuitive, and most importantly, it has clinical value, it will get used. And I think there's a lot of value in bedside consultations, remote consultations, or clinic consultations being supported by having the images there. The visual impact can be important. There was a really good presentation from one of our customers who said, I've got the quote here, he said, "Now I can pull up the patient's cardiac catheterization images in my clinic and discuss it with the patient. So if we don't work together, any of these lesions could cause you a heart attack. Look carefully at these images of your heart. Look at them at home and show your loved ones. We all need to work together to prevent you from having a heart attack." So I think that was pretty powerful. And it goes back to that old adage of, a picture being worth 1,000 words. And for some patients, seeing that visually is very impactful. So what does the future hold? I think we'd be remiss to ignore the big AI elephant in the room and talking about the future of any aspect of healthcare, let alone just imaging. Some of the technology we see around today is absolutely incredible. And if you look at what some of these AI systems are capable of, and I think what's more exciting still is that this technology is very much still in its infancy. So with this, we really, from an enterprise imaging perspective, need to start considering how best to manage the data flows that, in my opinion, in the future are going to be there to feed both human and machine interpreters. The data flow thing and cleanliness of data and all that's a challenge that's been there the whole time, but I think it will become more of a priority. Dirty, cluttered data is no good for training AI and for effectively and efficiently running AI. My view is that it's probably more important now than ever to start to get your house in order as we start to feed these algorithms, start to think about decluttering an organization and think about Marie Kondoing your image data. I think that analogy is probably a bit of a stretch, but bear with me. I think in order to provide sort of, clean, normalized and appropriate data in as streamlined a way as possible, it's important that your imaging data sets are decluttered, sorted out redundant, obsolete, orphaned data and make it organized, a place for everything, for efficient storage, routing, retrieval of images. And, by getting that structure in place and that organization in place, you set yourself well up for a system that will stay effective and efficient over time. So I know we were supposed to keep this brief, but thanks very much for the time. It's a really exciting time for enterprise imaging. There's a lot to talk about, but thanks again for having me on. Take care.
That's a lot to unpack. What are your guys' initial thoughts about the comment?
There's so many great points in that recording and a lot that I think that we can talk about. First thing to acknowledge is we're celebrating our 10-year anniversary of the SIIM Enterprise Imaging community. But as he just mentioned, enterprise imaging has been going on for a long time. It's been happening at organizations for several decades, and it's becoming more organized and more possible. And there's more imaging data that exists, but it's existed for a long time. The real benefits of enterprise imaging are a lot of the things he touched on. And I love what he said about creating the patient's timeline. It's the timeline of their life. It's not their only story, but it's their medical story. And we're doing things in enterprise imaging to help enable people to collect and tell that medical story so that other people providing care for the patient and the patient themselves can hear and see their story in pixels. And it's not just radiology data or cardiology data, but it can be from the embryo through beyond death, as he mentioned. I like that a lot, but it gives us that ability to have a holistic view and bring together all the specialties together.
I thought that was really fun too. It made me think about, my children. We have a digital photograph or video of every single thing that's happened in their lives. We don't have that at our age because so much happened before everything was digitized.
Mm-hmm.
But from birth until death, I mean, somebody's going to take a picture of every big event of my kids that they've had. So this is the medical equivalent of that. And I think it's important because these are discrete events along patients' lives that need to go far and wide to all the care providers that need them, all the people that need to know about them.
That's one of the challenges, though. So in your family's archive, your family keeps all those images. And maybe in some ways they're disconnected. Your cousins take photos and it lives on their drives and you don't have all the photos your cousins take. But you may have a way to get them. It can be harder in medical imaging to cross institutions to make sure that you're collecting it and that providers have the ability to see that data to use it to take care of patients.
Yeah, particularly where you're at, where you've got another large institution across town, people go back and forth.
And even where I'm at too, right? Like I have working at a children's hospital, I may have birth through 18, but I may not have 19 beyond. And you may not have the pre-18 stuff.
Right. Particularly if they're coming back for some chronic congenital something. Yeah, you're absolutely right.
Or day-to-day stuff. I mean, I went to an eye doctor and I got pictures of my retina. They're not at my hospital. I don't personally have them. I don't have an easy way to get them. Right. But there are photos of me that exist at my eye doctor that if I needed them would take some work to get to.
He brought up some other elements of enterprise imaging that to me are really crucial. One of the things that I really see as our goal in building enterprise imaging is making it easy to use. And he touched on that. There's so many bad workflows in medicine. And if done right, the imaging informatics tools can reduce that work. Like using some of our standard-based practices of things like a modality work list, standard naming schemas, orders or encounters to drive workflow. That helps to take away steps from the people entering data and remove some of their work, hopefully making it easier for them to do their job and to do it well.
I like what you said about the Maria condo. And we often hear, people want to integrate POCUS to the PACS in the absence of having encounters-based imaging workflow in place. And they have motivations to do this probably because they have to bill against it and they have to prove that they've stored it. But we have to make sure what we're storing is sound and is clean. And I thought that was a really salient point he made there.
The other question that also raises, aside from like POCUS, but patient uploaded imaging, right? Whether it's skin lesion, sometime for medication compliance, they'll want to have a video of the patient taking pills showing that they've actually taken it, things like that. So the patients may label it X, Y, and Z or whatever the default is, but that's not necessarily how we'll have it in the system. So what's the new naming convention? How do you want to, right? So he does make a good point about how this is all going to be stored correctly so that you can get to it and know like, okay, this is this date, this time, other than looking at metadata stamps and things like that, like the actual, whatever it is as part of the naming or the file system.
When we think of that longitudinal view and being able to access what's in the other organization, that we also have to think about making sure that it's going to get localized properly so that, there's a foreign patient ID in that other hospital. And now I'm bringing those studies in and it's not going to match against the patient jacket if I don't. So there has to be automated mechanisms of doing this. We have to think about that. Yeah.
It's so hard. And those are things that maybe we've not done well in imaging informatics to date. Things like procedure description are mostly not standard. Even though standards exist, organizations have not deployed those. And there's opportunity as enterprise imaging continues to mature that we avoid mistakes like that for other specialties. He mentioned two other things. We've already touched on patient engagement. Enterprise imaging is a great tool for engaging patients, whether that's the cardiologist saying, you have some very significant heart disease and we need to work together to help you improve the heart disease, or to see how their skin lesion has changed over time. You see it every day on your own body, but you don't realize over the past 3 years, it's been slowly growing or changing. Imaging helps you to understand the story of your health, and as much as it helps the providers provide that health care to the patients. And imaging is powerful.
His discussion about the cardiac patient example reminded me of a few years back at SIIM, somebody had talked about imaging consulting. So a patient could sign up for a time to sit with the radiologist and go over their images and like, oh, yes, this is what your tumor looks like. It is the size of a softball. And then go through the images and explain what the report is and everything. And then the radiologist would generate a consult note, a letter, like any other consultant would, and send that to the primary physician or clinician. And then, so that made me think of that. We live in the imaging sphere, so we use these terms, we understand what these terms are. So I got some feedback from somebody the other day. It was like, oh, you said worrisome for erosive osteoarthritis. Yeah, the primary care docs kind of freaked out because you said worrisome. I'm like, well, I mean, okay, I get it. Like I was using worrisome and like, yeah, I'm heading that direction, but not worrisome. Like this is cancer, like 5-alarm fire kind of worrisome, right? So I'm like, okay, that's good feedback. So we're all used to these terms and what we're using and whatnot, but patients aren't, and there's tons of stories like where like people get called like, my daughter's not a degenerate. You said degenerate. And it's like, she has degenerative disease, things like that. I'm sure
I'm used to being unremarkable.
Yeah, exactly. Right. But mom says I'm special. But, so being able to use enterprise imaging so that they can see the timeline and they can see these things and then have a better understanding of their health and how what they're doing actually makes a difference. And you can get buy-in from the patients that can be very powerful.
There's a whole new set of empowered consumers, right? I think about my grandparents and, doctor, whatever you want, whatever you think is right. They were very deferential to the healthcare industry in general and the leadership physicians, whoever that physician was that was in front of them. 21st Century Cures Act, everything is digitized these days, and it's entirely different culture around patient ownership of their own data, of their own healthcare. It's not completely there. I mean, federally, they've been pushing this for many years, trying to empower patients to own, here's what my insurance should be, here's what it's going to cover. And we're not there yet. But I do hope that over time, as technology evolves and makes more of this accessible to patients day to day, that they start expecting that everything is going to be integrated in the patient portal in places where they can access it, where they can move it from clinic A to hospital B. And it drives some of the adoption. It drives some of the change that we would love to see here. We're still very early in the enterprise imaging journey. Mm-hmm. As much as we've done in 10 years, there are some big spaces where it is not normal. It is not the norm. And we've still got many years ahead of us to get to something that looks like what we'd ideally want. And over that period of time, as all of that happens, there's going to be new use cases. Bringing up, regular photos of a fetus, never thought of it before, right? Digital path is going to explode. All kinds of things are going to explode, and new stuff's going to arrive, and we need to be ready for that too. So there's still a lot of runway ahead of us with enterprise imaging, even as much as we've done in 10 years. It's
interesting about accessibility and then privacy of the Cures Act. And we have within HIPAA, there's guidelines around that accessibility. But then at least my experience is that a lot of times privacy officers, they want to either build a bridge or build a wall. And so it's always good to work with the ones that want to build bridges. But I see it often where you want to carve out this space, you want to protect your boundaries. And even though the technology can support this transportability, we have policies that sometimes hinder that ability.
That sounds like a whole podcast in and of itself. I don't know if we want to talk about it now, or he touched on viewers. And I think there's some discussion of viewers. He didn't go into it, the things I think about with viewers, so it may not be the right time to bring it up. But I think of viewers with enterprise imaging, and I think of three types. There's specialty viewers, which are the traditional radiology packs, cardiology packs, pathology packs. To me, they allow the specialists to do their special things with their special images and act at that expert level. Then there's enterprise viewers, which allow everyone to see the images that they're not specialists for. Everyone is a specialist for some sort of image and not a specialist for every other type of image. And largely those enterprise viewers collect all of the images and let us see them. He talked about them typically being zero footprint or at least lightweight because they need to work through the electronic health record to be able to be mobile capable, to be in patient portals. That's the great part of an enterprise viewer. The last realm of viewers, which a lot of our vendors are striving for, is the universal viewer. And I liken that in Lord of the Rings. It's the one viewer to rule them all. where it would allow specialists to do their special things at every specialty level and allow for that generalist to view all the other images. So it could be the thing where it brings them all together. There are lots of challenges to get to that third one. I still see that as a very long way off. But definitely the first one, the specialty viewer and the enterprise viewers, are in hospitals today and being used pretty widespread. And I think that's a change over the last 10 years, and especially where they're bringing images together from other specialties. So over 10 years, we've seen a real growth in the enterprise side of viewing. Mm-hmm. It's been hopefully refreshing. We've also seen those viewers move to patient portals, which has been refreshing, allows that patient engagement we've just been talking about. And so we have room to continue to improve, but we've come a long way over the last decade.
I was actually, when you mentioned patient portals, I was going to mention a fourth viewer, which is the concept of these lay viewers, where if they're stripped down from tools. They may include the ability to be able to understand what unremarkable in these terms mean. And then there's different approaches like hovering over, but those are interesting journeys, I think, as we start getting into more patient access and what does an ideal patient viewer actually look like.
Yeah. So this brings up a kind of an interesting question of, so as a radiologist, when you're looking through stuff, you see certain things, and whether or not you have access to patient information, whatnot, we'll say you don't. So then when, let's just say we're looking at a chest, right? Chest CT. And then the pulmonologist is like, oh, hey, this actually makes a difference here. But to us, it might just be, oh, this nodule, nothing to worry about, blah, blah, blah. But then the pulmonologist is like, no, this actually isn't something. And they do a markup, right? And they may have put it in their note. But you have no idea as the radiologist that there has been an additional markup on there and more information that might, oh, this actually is okay, now let me, so that means maybe this lymph node over here that was kind of borderline, maybe that is more worrisome than I thought. I'm just throwing out an example. I think you guys
worrisome in what way?
I know, right? Oh no. Yeah. It's like, so as these viewers, like how, like the permissions and things like that, because, in the past it was everyone had, that wasn't outside of radiology had like viewer light, and they couldn't even do basic markups. Like, so how do you guys think that these things are going to change? And then do you give patients the ability to mark up? And then as the radiologist, now do you suddenly see patient markups, and what do those mean? And this kind of goes down some interesting ways. So what are you guys' thoughts on?
So I'll give you my perspective on this. I'm going to come back to your example. So we all have phones in our pocket that as I take a photograph, it knows who's in the photo because of facial recognition. It knows where the photograph was taken because of GPS. It knows all kinds of things about those. And it's stored in a way that I don't have to organize my own photos. This gets to AI that he talked about. Alex had talked to potentially body part labeling that you hinted at earlier. One of the things that I wonder, if I think pie in the sky about 10 years from now, Prasanth, going to your example, is as all of us move all of our data to the cloud and we put it in a place where humongous companies who have lots of resources and are investing billions of dollars each quarter in AI can apply some of that to the data that we have to help us better organize it, they're going to organize it better than the physicians will themselves. Let's be honest. AI organizes my photos better than I do myself. AI is going to organize all of our clinical multimedia better than my clinicians across my organization will too. Add to that, a lot of electronic health records today are moving in the direction of generative AI type summaries of patient information, right? So this was presented here at SIIM24 in one of the EHR user groups that we have, where they are synthesizing, here's everything you need to know about this patient, radiologist, the things that are relevant to your interpretation of this next study. What I wonder is if all of a sudden we're synthesizing all of that imaging data against synthesizing something that's in a pulmonology note about this pulmonary nodule and this lymph node, right? All of that gets delivered back in a way that's consumable to frontline folks like all four of us who take care of patients, right? So I think there's going to be, over the next 10 years, a great synthesizing of digital information around enterprise imaging and healthcare more broadly that makes this much more easy to do and doesn't rely as much on the humans doing the work. I may be wrong on that. Maybe it's one of those predictions that's going to be egg on my face 10 years from now and you can hold me to it. I'm at least hopeful that that's the direction, right? So that as that pulmonologist in your case needs to share information with us, right, it isn't something that they're sending us a message over email or sending us a text page or something like that. It's something that gets synthesized through generative AI as part of the electronic health record and served back up to whoever is next in the imaging chain to make a decision about what do I think about this lung nodule the next time they come in.
Mm-hmm.
So again, maybe pie in the sky, but I'm hopeful that AI is going to do a bunch of that over the next 10 years.
I don't think it's pie in the sky at all. I think that's exactly what's going to happen as well. And I think the enterprise imaging community has been building the hooks that will enable that. Some examples, interactive multimedia reporting is a great way to start pulling out the data, labeling it, saying this is important and these are the images that are important. The body part labeling that you talked about. Not that humans need to apply the label. The computer could eventually do that, but we need to pick what language we want it to apply to from a coding sense, not English versus Spanish or another language. Those type of things we're working on to make it so it's something feasible. I think we have work to do as well in things like procedure description and how to standardize that, but those will come. Some of the challenges from a markup today, I don't know who did the markup. And if you're doing it in a viewer, I might be able to see an annotation. It may be in a standard format. I'm sure there's metadata there that says who placed the markup somewhere in the system. Sure. It's not exposed to the end users yet.
Right.
And it's important for me to know who made it, if it's been changed from when someone else made it. That type of markup history needs to happen to allow us to take the insights and to drive downstream notifications if that's what's needed, or to know that change is happening.
Yeah.
Well, that was a very good discussion.
Yeah.
Thanks, Dan.
Thanks, Dan. That was a great recording.
I've only met Dan once, but I think this is a testament to like the community that we have.
Yeah.
You know, he reached out to me on LinkedIn through like our mutual connections through SIIM and so on. I just think, you know, you really get to experience a wide network of people and, really great individuals that we get to work with.
Can I double click on that for a minute? So I think of all the things that we've done in the enterprise imaging community for the last 10 years, the biggest output that we've had is not white papers, is not webinars, is not presentations anywhere. It actually is the group of people that are concerned about this, the group of people that are trying to now figure this out. And it's something that it does require resources. It requires human resources. It requires corporate, prioritization. A lot of those things are very simply necessary. And I think that has been the biggest, most important product that we will see from the last 10 years for the next 10, because there are people, consultants, clinicians, right, IIPs, who this is their life's work. It's a very important one.
Yeah, it takes a lot for the organization and getting all the stakeholders together. You definitely need support from the administration. Everybody has to be on board with this is the direction we're going, because it affects everybody. Because we're all going to start, not just everybody puts stuff in a blob server, but we're all going to start standardizing security. We're all going to start standardizing this and that. So it's like, oh, the password's no longer on the Post-it note. No, we're using a standard format. We're all going to name things the same way. So suddenly everyone's workflows change. But the benefits are a PACS administrator can walk over to GI and say, oh, what's wrong? This is a DICOM-enabled unit. I know your standardized stuff. I know how you do stuff. I can help you because, your normal person is on vacation. Fine. Anybody can step in. It allows for many of those amazing kind of benefits that, we talk about in like the white papers that you guys have all written and whatnot. But it does take a lot of time and energy to get the ball rolling and get everybody on board with it, because it is a lot of change.
Okay, so this next one is from Paul Lipton. We all know Paul from AGFA. And let's see what he has to say.
When I think back on the last 10 years in enterprise imaging, there's a lot of really great opportunities that I was able to take advantage of in the industry. We've seen 60 plus service lines at various different hospitals get on board with the idea of enterprise imaging and really introduce their images as part of the complete medical record. And the adoption was so strong in some of the hospitals that people couldn't keep up with the demand to get images as part of the official medical record. We've seen tons of cases where people have needed to previously drive into the hospital to see images in certain cases. into need to walk into different departments. And after having enterprise imaging in place, there's been so much good feedback in terms of having people being able to see the images that they need to in the EMR. The groups that we've worked with within the industry have been amazing. We've seen so many people involved in trying to solve a really unique problem in the medical record, and it's really paved the way over the last 10 years towards having more discrete data available for us to draw information from and to make better decisions from. Departments that have previously had siloed information are now part of a medical record that can then be shared, brought into AI and other places and used. And you're seeing a lot of papers coming out about that now. So a lot of really big improvements that we've made in the industry with enterprise imaging. It's been so amazing to actually see how challenging it has been for some of the departments over the years that previously never had any voice, right? We brought them a voice in enterprise imaging as a concept in these hospitals, and so many people have gotten on board with it, and these different groups have learned that their images are part of an important record at the hospital, and that IT groups within the hospital can make better use of those images in the future. So those are kind of the big ones that I've noticed in the field when working with our customers and working with other partners in SIIM and other places. The organization of SIIM and the community have really come together to make something great. During COVID, we got a little off track during COVID because we were so focused on other things, but we're seeing again a resurgence of groups looking to better organize their imaging information in the medical record post-COVID. So, it's back and hot, and we're seeing a lot of people interested in trying to move their images into the right place. So the movement has been very strong and made a lot of improvements in the industry. And kudos to everybody who's worked on the various IHE profiles, worked on the working groups, presented and brought their information to SIIM over the years and HIMSS and worked on these items. So very proud of the achievements that we've all had in enterprise imaging over the last few years. And it's been quite successful in the hospitals as well. And patients and providers and everyone are really better off for having access to the information that was previously siloed away. Thanks.
I definitely would echo some of what Paul's saying, because when I was at Utah, I literally took the white papers that you guys wrote to the CMIO and said, this is why we need to do this. I know these are going to be great paper. It's going to make the argument for me. And all the work, there's tons of work that goes into all of this stuff. So like you said, there's so much energy that goes into it. It's amazing that everyone has been able to stay on focus and task with this and move things forward to where we're at today.
There is a lot of energy around it, a lot of good energy, a lot of good momentum. Remember, though, that the people that you're taking those white papers to hear from a lot of different groups, right? So that CMIO, that CMO, the hospital presidents, whomever they are faced with inflation, higher wage costs for all of their staff. They're faced with more challenging reimbursement environment than they've ever had before. They're faced with mergers and acquisitions and consolidation across the industry. They're faced with, so many different things, that competition, that make it a more challenging environment than when enterprise imaging started. So when enterprise imaging really started, 2014, we were in the throes of putting in electronic health records. There was a much better economic picture, right? There was money coming as part of meaningful use, right? A lot of excitement around putting the EHRs in. That is something that takes rejuvenation. It's something that takes constant pushing by those of us that are trying to do it, to remind everybody that this is an important patient, expectation of our organization. This is an expectation that has, in some cases, a financial ROI associated with it. If all of a sudden we can save all of our point of care ultrasounds, right? Alex wrote that paper. That's something that ultimately is a win and should justify more investments of people or software. So it isn't something that we can just rest on our laurels of all the good stuff that we've done before. We need to look ahead and continue making the case, because there are pressures in all of our organizations that require us to outcompete the other requests that are coming from other sites.
I agree with everything you said. 10 years of enterprise imaging is an opportunity for us to look back and then to look to the future. I like how Paul brought that into his comments. I want to highlight some of them as well. from the enterprise imaging community. So over the last 10 years, the enterprise imaging community has published 17 white papers now, including 4 this current calendar year, 2024. Those white papers have been downloaded well over 100,000 times and are used to influence the industry. We've definitely seen that. The enterprise imaging community has helped to propose 4 IHE profiles that have been adopted at this point. We've proposed others that were decided not to be adopted or voted on, but 4 that have been adopted. There's a digital imaging adoption model that is around. And then we have all of these educational sessions that have happened at various conferences, webinars, podcasts, well over 300 of these type of educational opportunities through the enterprise imaging community that have been attended and consumed by thousands of people. So it is something that the community is making a difference. As we look forward, as Chris said, it's important for us to say, how are we impacting healthcare positively in our future? And that can be done in many ways because there are competing interests, and we have to say why we should be spending money and time and effort on enterprise imaging. And so that some of those things, enterprise imaging helps to reduce work. If it's done right, as was mentioned on some of the earlier comments, a picture's worth 1,000 words. You could start typing less and dictating less or creating fewer notes if you have imaging. You still need some of the words to explain it, but it is less. If you have good imaging workflows, you're entering fewer things into machines because the machines can do some of that work for us, or we're using standards. Enterprise imaging can make money. Point of care ultrasound brings in money. It allows for revenue capture. Other things like ophthalmologic imaging can do revenue capture. And so it's a way for organizations to make money in the care that they're providing. And so it does a lot, but we in the community need to be able to express those things as well when we're going to our C-suite and saying we need to invest in this, and here's why.
Especially with enterprise imaging, as important as it is, probably doesn't seem as sexy as AI does, right? Because right now AI is the hot new thing, right? 10 years ago, it was cloud computing, right? I remember.
I'd say, yeah, but AI doesn't happen unless you have well-organized annotated data.
Agreed.
And that's what enterprise imaging and imaging informatics does. And it gets it all in one place, and it co-localizes it with the other imaging data across specialties. So it allows for that multimodal data sets that all of our researchers want.
Yeah. And to your point of, patient care, like there's so many more ties between, dental care and dental health and systemic health, but we don't have a lot of the dental data coming in, right? So if you can tie those together, and then with the ophthalmological, because, with the, like diabetes, right? Things like that, like now you have a whole view or a much more broader view of the patient to give them better care. Yeah. Right.
Yeah.
It's funny because dentistry is often, we hear the specialties, that's not one that gets listed very readily. And I know that Monique had mentioned that Saudi Arabia had done a big initiative with dental registry and so on, but that's a really good point. Yeah, it's such a marker for your overal health, but we don't really evaluate those images in a holistic way often.
Or even have access to them.
That's the problem. A lot of dentistry happens in office-based settings that are not connected to hospitals or the provision of other, where healthcare is provided for other specialties. And so because there are physical walls and streets and a lot of distance between them, so they're never part of a healthcare system, or very rarely. And so getting access to the complete record, like we talked about earlier, is still a real problem in the United States for sure. It may work better in other countries, but I would guess dentistry is still outside in other countries as well.
I'd like to see images from the zoo.
Yeah.
And things like that, because how cool is that to I know it has nothing to do with human health, but it's like looking at like the CT, like I had CT of a dog's sinuses, and I'm like, what the heck? Like,
I'll show you an anteater CT.
Oh, that'd be great.
Yeah.
It's also good for comparative anatomy when we're teaching it, okay, this is how this works. This is how that works, so that you can understand humans, how we work better, right? So there is an educational point to it, but it is still kind of fun to look at some of these.
So that gets to the evolutionary biology of all of us, and it is pretty cool to see.
Right.
Paul had a few other points to highlight. One, he mentioned the pandemic. The pandemic hit us all. There were times that caused us to pause, but it forced us to innovate. And I think we should highlight that as well. All of a sudden, we had to make things work, and enterprise imaging was a big part of it, whether that's enabling others to take images. It helped to push POCUS in many areas because it became a method of detecting COVID that was not X-ray, and helped to limit the number of people that were in the hospitals at that time. It helped to reduce some of the squabbling that happens between specialties and turf battles. So there was innovation that happened because of COVID, particularly in enterprise imaging. I think you probably saw that at your organization as well, Chris.
Yeah, we did. We saw a lot of the same things that you did. And it really did put a bit of a damper on the growth of enterprise imaging. We had a lot of momentum before the pandemic, and then, pretty much everything across the country stopped. Let's solve this one big problem. And all of a sudden, groups are trying to catch back up. Imaging, non-imaging, everybody's sort of resetting their priorities and their organizational priorities. So, again, as I said, it is something that requires, regular communication amongst the leadership at your organizations to advocate for the things that are the most important. And the benefits that clinical multimedia and enterprise imaging can actually bring are pretty big, especially around AI. Alex talked about it a little bit. It's a big growth space right now. There's a lot of interest, not just around pixel-based AI, but generative AI and the implications of it. So I do think those are synergistic. I think AI and EI hold hands and work really closely together and can share the same meeting space and advocacy efforts.
And then another thing Paul brought up is 60 service lines not being able to keep up with demand. And so there's a few things to touch on in there. One is the keeping up with demand part is governance. I would guess, Chris, you have some things you'd like to say about governance around enterprise imaging. I'm teeing you up for that. But the point of enterprise imaging is enabling all those service lines to do the work that they want to do, to provide the care that they are experts in providing. And from the enterprise imaging side, letting them do it in the way that they want to do it. So applying good enterprise imaging techniques or imaging informatics techniques to a specialty, not forcing another specialty's workflow on that specialty. Right. Again, there's a lot of power there, but it takes time. We're a lot of times inventing new workflows by using the imaging informatics tools, but allowing providers to do it in a way that they want to do, in a way that makes sense and is efficient for them. I'll pass it to you.
Yeah. So part of my role now is I'm a radiologist as board certified, but really most of my job is chief cat herder for imaging across Duke Health. So leading the service line for imaging gives me a lot more influence over what's happening in ophthalmology and obstetrics and cardiology, other diagnostic specialties. It gives an opportunity to convey best practice and, here's the potential pitfalls of what you're doing to dermatology, the OR, plastic surgery, any of those kind of groups. And I think it's important to reiterate, and this has been said before, that you can be a radiologist, you can be somebody who understands those things and sort of provide that information, but you can't thrust your workflow on those other groups. It's not going to work. You have to be somebody who almost is more on their side than you are than a radiologist. And it gets me into trouble in my own department sometimes, more than sometimes. I feel like I go out of my way to advocate for some of these other groups, and I'm doing it at the expense of an important radiology thing. So for the clinicians that are out there who are leading enterprise imaging efforts, I think it's critically important that you engage and communicate with those other specialties so they see you as an ally, they see you as somebody who's beneficial and not somebody who's trying to take over turf, not somebody who's trying to thrust something that is square peg round hole upon the way they do work. And those are things that, it's blocking and tackling. It's very basic stuff, but it's something that takes time. It's something that you have to build up, to Alex's point. You have to build up that trust over time. You have to build up that expertise over time to really learn how does point of care ultrasound work in the ICU. It's very different than how it works in a point of care clinic, in an ambulatory clinic. So there's a lot that you have to learn if you're in the job of running enterprise imaging for your organization. It's a big job. It takes a lot of time. And you have to be really open-minded in some cases to the detriment of a lot of your friends who are in the specialty that you have.
So how do you guys balance letting the different fields do what they want against standardization, like we were talking about before about standard naming conventions, things like that.
Yeah.
So there's a tension between the two because you want to let people do their own workflow, but at the same token, you want some amount of standardization so there's interoperability and things like that. Like, what are your guys' experience?
It's transparency and communication, right? We have great experience that a lot of those groups don't have.
Right.
So part of it is having the governance body in place, whether it's an IT governance body or it's an operational governance body that has the charge to go make said improvements, whatever that thing is, and bringing the experience, decades of experience of doing this can help explain part of why them doing it their way doesn't make a whole lot of sense. It doesn't necessarily need to be my way, but here's why your way doesn't make sense. And let's have a discussion about that. Let's make it productive. You build relationships. And that really, really goes a long way. It's a soft skill, but it's an important skill. So to me, I don't think it's, a hard mandate. You can set some hard mandates, right? For point of care ultrasound, as an example for us, we, in July of 23, got together 35 people for 4 hour-and-a-half long meetings in the month of July. We hit on what are the credentialing requirements. We hit on what are the preferred vendors for our organization. What are the mandates for workflow? Some very specific hard things like that. And there were 20 physicians, one from each specialty, and they all had different ideas. And it was hard to do, but eventually we got to, an image must be captured, image or some video. You have to have a discrete result against that image, which is really uncomfortable to some folks because, they are not in that habit. And having a discrete result, not something buried in a clinic note, not something buried in an op note, is hard to do with the tools that we had, at least. And third is if you can bill, you bill. Right. And you need to understand billing. And that, again, is really uphill for a lot of those folks. So we had to make the case that, look, radiologists have been doing this a long time. It's not like we want to interpret all of your stuff. We can't. We don't have enough people. But here's where the expectations are from risk management, and compliance, and revenue, and credentialing. All of these people, doctors that you don't talk to very often, that I hear about all the time, about why is this all screwed up? Here's where we need to go. And you run a project like that, and all of a sudden it becomes successful. Right? Because you're discussing it in a productive, professional way with everybody. And then rinse and repeat that with camera phone photos, rinse and repeat that with other things as well. And all of a sudden you have not just better process and billing and compliance, but better relationships. So that's how, to me, you really do it, is transparency and communication around those relationships.
So we are coming up at the top of the hour here. And so I just wanted to give us a chance, I guess, thanks to Dan and thanks to Paul, but any closing thoughts that either of you have? It could be anything, dealer's choice here. So anything you want to just finish with?
I want to end with an anecdote that's going on right now in my life. So while we've been talking, I got a text message from my wife saying that my son needs an x-ray. And because of Enterprise Imaging, I can, while we're talking, log in through the patient portal. So I'm doing this legally for my compliance people. I'm going in another way. I'm going in through the patient portal and look at his results and look at the images to see what's going on. And I can do it in real time while I'm in Washington. My family's back at home.
Do you agree or disagree?
And if I agree, and then I can text my colleague and do something else. I trust my colleague.
I know.
Will be correct. But that's what can happen with Enterprise Imaging. I have advantages and I know how the workflow works, and I created the workflow, but any of our patients could do these things, to see their images and to see their results. It's instantaneous.
I can't top that. Period. End.
I hear you. Well, thank you very much. It was terrific, and we appreciate you guys taking your time. We know you were both very busy at this meeting, so thank you. And I think that's it.
Thank you both.
Thanks for doing this.
Yeah.
It's been fun to be here.
Thank you.
SIIMcast has been brought to you by the Society of Imaging Informatics in Medicine. Please visit our website at SIIM.org for more information and educational content, including webinars and an archive of prior episodes. Please follow us on Twitter at SIIM_tweets. Thank you to our listeners for your continued support.